good afternoon to everybody, and we welcome you for this instruction course. And I would like to thank the AIOS for giving us this opportunity. Now, in this instruction course, which is on the roller coaster of trabeculectomy and how do we have a successful outcome of a glaucoma filtering surgery. So, we will be talking about the tricks and the tips that how do we achieve the successful outcome after trabeculectomy. And I think all of you would agree that trab is one of the surgeries which most of the anterior segment surgeons, whether they are qualified glaucoma people or they are not qualified glaucoma surgeons, they would like to do a trabeculectomy because everybody feels that this is a very, very simple surgery. But once you have done a number of trabs, you realize that though it appears very simple, but there are a lot of complications which come along with trabeculectomy and which you have to learn to manage. So with this idea in mind, we have designed this instruction course which will be talking about that whenever you decide to do a filtering surgery in your glaucoma patient, how do you choose the right surgery, and what precautions do you take intraoperatively and in the post-operative period to increase the successful outcome. And who could be a better person to give the introduction to this instruction course than Professor J.C. Das. I think he needs no introduction. He's been one of the most senior glaucoma person countrywide, and he has taught many of us. He has had so many years, almost I think nearly 50 years of experience in teaching profession, and so many students have come out of his guidance. He has been a past president of Delhi Ophthalmic Society and the Glaucoma Society and have innumerable publications and awards to his honor. And he is one of the first ones who bought actually the glaucoma drainage device also popularized in our country. So I think I would request Professor Das to give us introduction for this instruction course. Sir.
Thank you, Dr. Parul, for the kind words. And welcome to all of you in the practically lunch session. The thing is, we choose glaucoma surgery when drugs fail. In most of the cases, the primary cases are very few and far between, and that depends on the personal choice of many people. But as a routine, most of us do trabeculectomy as the first choice, and we feel that the end of the story. No, it is not the end of the story. Actually, this is the beginning of the whole story. Once you resort to surgery like trabeculectomy, you are heading for complications or failure rate very soon. If you consider the success rate, the success rate reduces to 60 to 70% in 2 years' time, and it reduces to 40% in 5 years' time, and that continues. That means almost 60% of the patients are likely to fail in 10 years' time maximum. That means we have to repeat the trab again after 10 years. If the patient's age is 20 years, every 10 years you repeat the surgery then. So this becomes a difficult proposition. Apart from the success rate, when it didn't work, then we thought of using mitomycin C. Success rate increased tremendously, but at the same time, the complication rate also increased very, very high level. The complications like bleb thinning occurs in roughly 60% of cases, and one study shows it is 67%. Bleb leak in 15% of cases in 10 years' time. Infection, patients lands with, one of the reports shows in 85% of cases there is risk of infection, and that infection has really happened. So if that is the complication rate of trabeculectomy, where do we stand? Not only the complication of bleb-related complications, what happens to the cataract? In a normal young patient, 24% of the young patients develop cataract very soon. 47% of uncomplicated surgery ultimately land with complication or land with cataract formation. If it is diabetic patient, the chances are 75%, and if it is a complicated glaucoma surgery, then the chances are almost 90%. That means if you take minimum of this, roughly 40% of the patient is likely to develop cataract sooner or later. What happens to the fields? In spite of a successful surgery with the trabeculectomy, the field progresses 25% of cases in first year, and in 10 years' time, the field progression is found in 58% of cases. That means we have got the reduced rate of success, we have got the complications, and of the cataract formation, visual field progresses. Where do we stand then? So naturally, we are concerned that how to minimize these complications and increase the success rate. And to increase the success rate and the complications, you must choose a right surgery for the right patient. And certain surgery is good for a certain situation. Trabeculectomy is not a common surgery for all types of patients. So we have to pick and choose according to the patient's need a surgery which is suitable to us. And there are few basic things which are very, very important for trabeculectomy. The prevention is the best form of treatment. That is one thing very, very clear, one must understand it. Second, trabeculectomy is not just a science, it is also an art of treating a patient. That means each step, including preoperative preparation, maybe 1 week prior to this, and each and every step during surgery and immediate post-op period are important, and important to equal extent. So if you want to increase the success rate, decrease the complication rate, one must be very, very meticulous and to follow all the steps even preoperatively, during surgery, and immediate post-operative and later on. Nowadays, the more options are available. We have got more flexibility, and certain surgeries are not suitable for certain cases. That one must remember. For example, I'll tell you which are the surgeries which is soon to do or we should do. Say in general, if the intraocular pressure, the target IOP is less, then you go for a trabeculectomy with all the precautions, trabeculectomy with mitomycin C, or you can do a tube with all the precautions, or you can do a suprachoroidal type of drainage devices. If you feel that the intraocular pressure lowering is a must and it should be around 10, then you go for a surgery which is associated with a little more complication, but the target pressure is likely to be achieved further. If the target intraocular pressure is supposed to be little high, that means it's a mild to moderate case of glaucoma, then we have got a lot of options nowadays. And like all the MIGS surgeries, microinvasive glaucoma surgeries, including the GAT or gonioscopic assisted trabeculotomy and deep sclerotomy and trabectome, and all those MIGS surgeries are available when you feel that the intraocular pressure level should not be that low. We don't need it in the lower teens, should be maintained at 17, 16, 17, because the glaucoma is not very advanced, it is early stage. And more than what surgery you choose, it is more important to choose which surgery you should not do. That is more important. Like in medication, that which medication you should not use for certain situations, general conditions or local conditions. Similarly, you don't use certain surgeries for certain glaucoma type of glaucoma, that you must remember. I'll give you some examples. Say for neovascular glaucoma, for eye syndrome, post-VR surgeries, post-PK surgeries, where you expect that the trabeculectomy is likely to fail, don't do it, as simple as this. So go for another surgery like, or even in cases of childhood glaucomas, you prefer a tube with all the precautions you have to take. Second is, suppose we have got the aphakia with vitreous in the antechamber, don't go for trabeculectomy, is likely to be failed. So it is always better to do a vitrectomy followed by tube surgery. That gives comparatively better results. In cases of the collagen disorders, collagen vascular diseases, where you expect the scleral melting is common, don't use mitomycin C. So these are the things we must keep in mind. Other ocular surface disorders, where the like pemphigus or pemphigoid, where the conjunctiva is scarred, don't for the trabeculectomy at all, then go for the tube. For example, another surgery which is not very commonly done, we have to learn it, is the endocyclophotocoagulations, which can be done along with the cataract surgeries, and for a specific type of glaucomas like a childhood glaucomas. In case of neovascular glaucoma, choose a surgery like endocyclophotocoagulation. That is another better choice. And you don't do a gene type of implant in angle closure glaucomas, and if there is a lot of scarring, or in neovascular glaucoma, you don't do it. So avoid any such surgeries in cases of, if you are planning for gen implantation, don't do it in those cases. And GAT is the gonioscopic assisted transluminal the trabeculotomy is not done in cases of bleeding diathesis, or those patients who are already on the anticoagulants. So they are likely to land with repeated hemorrhages. So don't plan for GAD surgery in such situations. And for patients which are very obese, you may have to change your decision right on the table. If the patient is very obese, has got very thick neck and a short neck, likely to cause a positive pressure during surgery, likely to land with a suprachoroidal hemorrhage, better you don't go for conventional surgery with trabeculectomy. For example, if you are doing a surgery for a very high myop in a young patient, don't use mitomycin C, or use mitomycin C in the lowest concentration with the lowest possible time. So these are the things we must keep in mind, what not to do during the surgery. So many options are coming up. If you feel that these options are practical and you can do it, there is a lot of learning curve, though it takes very less time and looks very simple, it takes little time to learn. So it is better that we set up our mind to change the surgical pattern, keeping in mind the complication rate of the conventional trabeculectomy. With these few words, so I'll hand over to you to call the next speaker.
Thank you, Professor Das. And I think this was a nice introduction explaining that how one can land up in complication if you make a wrong choice. And this is precisely what Dr. Vinita is going to talk about. Dr. Vinita is a dynamic glaucoma surgeon. She heads the glaucoma unit at AIIMS Rishikesh, and she will be talking about how do I make the right choice and choosing the right surgery for our glaucoma patients. Dr. Vinita.
Good afternoon, everyone. नहीं मेरी है पर आपका क्या आ रहा है स्टार्ट कहाँ हो रहा है? Good afternoon, everyone. So as Dr. Parul has said, so I'll be talking about which surgery to choose for your glaucoma patient. And obviously, as Dr. Das has already enlisted the options which we have, starting from trabeculectomies, which is obviously the gold standard, the tube shunts, the minimally invasive glaucoma surgery, some of which he has named, and the cyclodestructive procedures, which may be required in certain cases, and with the recent introduction of the micropulse, which may be used as an adjunct to other surgeries. So you have to look for what surgery is going to be ideal for your glaucoma patient. As we all know, when do we plan surgery for the patient? Obviously, when his IOP is not coming close to target IOP and his optic neuropathy is progressing, and or there is non-compliance or any side effects of the drugs, or we can do as like the primary tube versus the trap surgery said, we can do it as a primary treatment also for a certain group of patients. But for each patient, we have to do a case-to-case analysis, and a risk-to-benefit ratio has to be done, assessing his structural changes and his functional affection of the optic nerve before we take the decision with surgery. Whatever surgery we are choosing, the goal of the surgery is that we should have minimal complications, a good long-term IOP control, precisely trying to reach closer to the target IOP and avoiding any visual impairment. So factors which we take into consideration when we have to do is the type of glaucoma, obviously, whether it is an angle closure glaucoma or an open angle glaucoma, whether it is a primary or a secondary glaucoma, whether it is a primary surgery or it's a repeat surgery. What is the status of the conjunctiva? Conjunctiva should be healthy. Is it scarred as it has suffered any other disease, or as like sir mentioned, there is an ocular surface disorder or a cicatricial pemphigoid sitting there. Obviously, the patient cannot have a conjunctival-based surgeries. Do we need to combine it with the cataract surgeries or any other procedure? What is the risk of complications for that patient? What is the risk of his progression? And what is his target IOP? All this has to be taken into consideration, besides the surgeon's own comfort level. And the other important factors is the age of the patient, what is his already visual prognosis, what is his life expectancy for that particular patient. All this also needs to be discussed with the patient before we go ahead with a surgical plan for the patient. So an ideal procedure should be anything which is fast, easy, low cost, low risk of complications, less stressful to the patient, repeatable, and with minimal complications. So, and it should also be at the same time able to achieve target IOPs with minimal circadian rhythms, without any adjunctive use of anti-glaucoma medications, preserving the visual function of the patient at all times, and a very long-term success of almost 10-year success rate is what we are expecting for an ideal procedure. For glaucoma surgery, it is not as simple, the decision making is not as simple as that for a cataract surgery. Why? This is because even when the surgery goes well, the post-operative period is fraught with complications, and patient may not be very happy. This is because patients, like for a cataract, they may be expecting that they'll start seeing better, but this is not the case for a glaucoma surgeries. In fact, there may be transient vision losses occurring after surgery. There may be development of cataract, okay? Besides this, eyes of the patients are continuously red and irritable for a few days, for a few months after the surgeries. They always do not understand the need for surgery because obviously, as we know, glaucoma is a silent disease. The risks of surgery, when explained to them, they tend to move towards a non-surgical option unless until they're explained in the severity of the disease. And especially when we explain them the vision-threatening complications and need for going and doing revisits to the operating room after the surgery. So, as Dr. Das mentioned, trabeculectomy, and as it is known in the glaucoma, to all the glaucoma specialists, is the gold standard as a primary surgery when we are doing it, except for a few cases which I'll be telling, which cases not to choose trabeculectomy as a primary surgeries. It has a high success rate, especially when we have taken care of all the modifications which are now being introduced along with trabeculectomies, with the fornis-based flaps, use of antifibrotic agents, and various suture techniques. So the course technique, which basically, as is depicted in this figure, using a larger treatment area for your antifibrotics, using tight, adjustable sutures or using releasable sutures, using a larger scleral flap, not cutting close to the limbus, a single punch of sclerostomy to give a good inner sclerostomy. So all these technique maneuvers which are done while planning your trabeculectomy will help you in enhancing the success of a trabeculectomy. The conflict which remains is mainly whether to combine it with cataract surgery and whether to use antifibrotics or not. So as we all know, the main cause of failure, early failure for a filtering surgery as well as for late failures is the fibroblastic proliferation which is taking place. So important challenge is to prevent this. And obviously, besides the anti-metabolite drugs, which is the 5-FU as well as the mitomycin C, we also have the amniotic membranes available now as well as the ologen spacer which is available. As Sir rightly mentioned, the trabeculectomy, if it is done as a naive technique without the use of any antifibrotic agents, almost 27% patients tend to fail within the first year. And with the use of adjunctive antifibrotic agents, we can reduce this failure rate. Obviously, it has been seen a single application of mitomycin C intraoperatively is much superior to postoperative applications and injections of 5-FUs. So now, in most of the cases, it has become an adjunct. Use of intraoperative mitomycin C has become an adjunct to trabeculectomies. But for this, what percentage to use, what time, how much time to use, and in what cases not to use, we have to assess two things: the risk of bleb failure for that particular patient, and the risk of post-op infection for that particular patient. So obviously, wherever the risk of bleb failure is high, I will use mitomycin C. Even in the intermediate cases, I will go with a lesser dose and a lesser time for mitomycin C intraoperative application. But if there is a high risk of infection, as I said in my cases, or diabetes, immunocompromised cases, or those with the lid diseases, in those cases, obviously, I would avoid antimetabolites. And also, we have to take care wherever we have, like I said, it is not fraught without complications, the use of mitomycin C as well. So we may land up with a weeping bleb, a leaky bleb, increased blebitis. So in order to overcome that, we had something called as, which is now augmentation of trabeculectomy using amniotic membrane transplants, which are based on these properties of anti-fibrosis, anti-inflammatory action, anti-angiogenic action. All these actions of amniotic membrane have brought this amniotic membrane as an adjunctive use within the trabeculectomy, where it does not require much of the modification to your techniques, but it gives you a better diffusely elevated bleb with low vascularity, fewer post-op interventions as compared to mitomycin C, lesser time, and just needs to incorporate as an extra step during your surgery. is readily available as in a dried form, and it can be done as a primary procedure, or you can add it with a mitomycin C depending on the patient's high risk of bleb failure. It can be used again subconjunctival or subscleral as we use for mitomycin C, and anchoring sutures can be applied to it. Or we can use something called as ologen implants, which again have given a good success rate in some cases. Ologen implants is again like a biodegradable collagen matrix, which is basically there were many studies done to see what is its efficacy as compared to mitomycin C, and a meta-analysis on this found that it is a safe and effective procedure in patients with glaucoma. However, it does not have any significant advantages. The cost issue is slightly much, obviously as compared to mitomycin C, it is more expensive, but obviously it does not offer you more advantages, but it is not disadvantages as well if the patient does not have cost issues. Expressions also came, but obviously expressions had a lot of complications to be used as an adjunct along with trabeclectomy. So obviously they had late complications, and their success and were also expensive. So they have gone out of use as an adjunct to trabeclectomies. Now the second important surgery which we do as a glaucoma surgeons is tube surgeries, is the most common alternative choice. So all complicated cases of glaucoma, which I have listed here, obviously secondary glaucomas, secondary to uveitis, post-PKs, neovascular, those were associated with Sturge-Weber syndrome, with eye syndromes, or with previous multiple failed trabeclectomies, with extensive conjunctival scarring, those with ocular surface disease, or efficient glaucoma where I cannot do a trabeclectomy, I have to do a tube shunt surgery. Now, which implant to use, which tube to use, whether a valved implant, Ahmed valve, or a non-valved bare weld implant. So there are various studies which have compared these, and they have found the efficacy of a bare weld implant as compared to IOP control is better in these studies for 3-year follow-up. However, the complications associated with Ahmed implant are much less and occur less frequently. Now, the third option which we have is what in those cases where the patient already has had a primary surgery. So if the primary surgery is a trab or a primary surgery is the tube. Now, if my primary surgery has been a trab, then I have to take the patient for a repeat surgery because of his failing and his progressive optic neuropathies. Do we need to do another similar surgery, or do we go ahead with a tube? So again, if we look at the results of the primary tube and the primary trap surgery, it showed that tubes also had excellent results. But remember, when we are doing a primary repeat trap, in a case when the conjunctiva is good, my second choice will always again remain a trap if my primary trap has failed, because I have the chances of doing bleb revisions, and I can always go back and do a tube if the secondary trap also fails. But if I do a tube as a first surgery, I do not have the option of doing a trap later on. So obviously the second choice, I'm going to a dead end in the sense that I'll be forced to do either a tube, again a tube if my first tube surgery fails, or I'll be forced to do a cyclodestructive procedure to bring the IOP under control or bring the glaucoma of the patient, prevent the glaucoma of the patient from progressing. Sir has already given an overview of the evolving micro-invasive or minimally invasive glaucoma surgeries, as we call them, which include the non-penetrating drainage surgeries like deep sclerectomies. These are only for the patients who have mild to moderate glaucomas. They cannot be done for patients with advanced glaucomas. So they are only helpful in the early stages of diseases. They require special instrumentation, and obviously the cost issues are there. So mostly procedures which are being done nowadays are the trabectomy, the use of eye stents, and canaloplasties. What is the role of these is more in combination when we are doing a cataract surgery in these patients, and especially when we are in patients with mild to moderate glaucoma, we can do these microinvasive surgeries along with the cataract surgeries as a single procedure rather than doing a separate surgeries. The last thing which I'll just talk about is the combination of cataract surgery with a trabeclectomies. The results and the studies have shown that the success rate of a combined surgery is usually not as favorable as a filtration surgery alone. So if you have to do a combined surgery, it is better to do them as separate surgeries so as to have a better enhancement, better success of a trabeclectomies. And nowadays with the micropulse laser, you can even do as a micropulse laser as an adjunct while the patient is waiting to your before your trabeclectomy or before your tube surgeries. Thank you.
Thank you, Dr. Vinita. Now, the next speaker, I invite Dr. Parul Sony, who is the chief instructor of this course as well. She will be speaking on preventing complications, preoperative, peroperative, and postoperative. I think this is the main, most important part of this. Okay.
You have got another session
So
now?
during
That
the
means
time
you could avoid the questions. Okay.
Due to the time that she's settling down, may I request everybody to come forwards, because a lot of people sitting at the back and front rows are all vacant. And just take few seconds and come quickly to front, the people sitting at the back. Okay.
Good afternoon, everybody. And I think Dr. Vinita very clearly pointed out that you have to be choosing the right surgery depending on what you want in your patient and what all other risk factors and what is the comorbidity that patient has in his eyes along with glaucoma. And what I will be talking about is how do we enhance the outcome of trabeculectomy by taking appropriate steps during preoperative, intraoperative, and postoperative period. Now, I think glaucoma is we all know is a silent disease, and patients have no symptoms. So whenever we are subjecting a patient to a glaucoma surgery, what they actually want is good vision without any medication and a comfortable eye. And what glaucoma surgeons want is a nice filtering posterior low-lying bleb with good intraocular pressure control without any medication from day one to almost maybe 10, 20 years and maybe beyond that. And what we actually don't want is any kind of complications, whether they are simple complications like hypotony or shallow anterior chamber. But what we actually dread is the vision-threatening complications like the suprachoroidal hemorrhage, the wipeout phenomenon, the leaking blebs or the blebitis or bleb-induced endophthalmitis, and the bleb failure. And I think all of you would agree that hypotony is one of the most important factor which is responsible for these vision-threatening complications. And when we talk about hypotony, it is the suddenness of hypotony which is happening during intraoperative period, or the duration and the extent of hypotony, which plays a very important role. So before we plan a glaucoma filtering surgery, it is very, very important for us to identify the eyes which have high risk of developing these vision-threatening complications. A patient who has advanced cupping like this, or maybe who has advanced visual field defect with the splitting of visual field can have, sorry, where's the pointer? So these patients are at more risk of wipeout phenomenon. So you have to take care that avoid hypotony at each and every step of your surgery. Now, preoperative assessment is again very important. All we want is a pristine, untouched conjunctiva. So if patient has had any kind of prior surgery, whether it's a penetrating keratoplasty, a VR surgery, which makes the conjunctival dissection very difficult, and the healing becomes more aggressive. So you have to be using antimitotic agents in such eyes. Again, you have to be careful in patients who have thin and inflamed conjunctiva. So it's always a good idea to check for the motility of conjunctiva using a wetted sponge before surgery. Now again, treating ocular surface is very important because these patients are on long-term anti-glaucoma medication, which leads to a lot of ocular surface disorders, the dry eyes. So treat blepharitis, put the patient on copious lubricants, and if possible, give the patient a drug holiday from the anti-glaucoma medication, especially if the patient is on PG analog, pilocarpine or Ripatec, which we have started using recently. It's a good idea, if possible, give a 3 to 7 days withdrawal from these drugs. And put the patient on oral anti-glaucoma medication, but you have to be careful that when you put the patient on these carbonic anhydrase inhibitor, tell them about the potassium intake. You can tell them to eat more bananas or tomatoes to keep a check on the potassium levels. And again, if you feel that the ocular surface is highly inflamed, it's a good idea to start a low-dose steroid 1 week prior to surgery. Now again, both kind of refractive errors, whether it's a myopia, high myopia or high hyperope, can be associated with their subset of complications. So you have to be carefully looking into these parameters also. Now, good systemic control is something which we cannot ignore. We all know that high uncontrolled blood pressure is a known risk factor for a suprachoroidal hemorrhage and a wipeout phenomenon also. So we should always ask patient to have a good blood pressure control. Stop anticoagulants prior to surgery, otherwise you can land up in excessive bleeding and difficult suture removal or a suturolysis in the post-operative period if you're planning for that. Again, diabetics, you have to be careful because these have high levels of VEGF and can have aggressive scarring and poor wound healing and are more susceptible to develop infection. Now, once you have chosen the surgery and you're taking patient for surgery, it's a good idea to have a good intraocular pressure control, though I know that is the main reason why we are going to operate upon that patient, but in the perioperative period, it is good idea to put the patient on systemic anti-glaucoma agent so that you have a good preoperative intraocular pressure lowering. Again, operate upon a soft eye. You have to give mannitol almost half an hour to an hour before surgery. And do remember to give bathroom break, because otherwise during the entire surgical period, the patient will be squeezing and the surgery might become difficult because you'll have a lot of positive posterior vitreous pressure. Use as low volume of peribulbar as possible. If you are comfortable, you can use for a subtenon or a retrobulbar block. Avoid any kind of super pinky or vigorous digital massage, and during surgery you can use a lightweight self-retaining speculum, which again avoids the positive vitreous pressure. Now you have to have an excellent exposure in the area where you are going to make your bleb, and especially if you're planning for a tube surgery, you have to be giving a good exposure. So for this now, corneal traction sutures have become very popular, and very hardly we are using brittle sutures which had their own complications. But whenever we are putting a corneal traction suture, take care that avoid full thickness entry or maybe too superficial a bite, which can lead to cheese wiring. And again, too wide a bite can lead to flap distortion and may interfere with the surgical precision. Now, coming to conjunctival dissection. Now, conjunctiva is a very, very sacred tissue and we have to handle it very, very carefully. Avoid any kind of tooth forceps. So, hold the conjunctiva with a serrated plain forceps, and if possible, hold the tenons and retract the conjunctiva using a Merocell sponge. And again, after conjunctival dissection, tenon dissection is also very important, because if you leave the tenons undissected, it interferes with both the making of a scleral flap and also with the suture removal in the post-operative period. Now, we all want is a good hemostasis, so we have to be carefully, either you wait for your bleeders to stop in some time, or maybe do a very gentle non-charring cautery. Excessive cautery can lead to scleral thinning. So maybe do a select cautery in the area where you are planning an incision and a scleral flap. Now, antimetabolites have actually become a third hand of our glaucoma surgeons, and it has definitely improved the success rate of trabeculectomy in last couple of decades. But whenever we are using antimetabolite agents, we have to use it in the wider area, so make it as big as possible. Use multiple sponges. Avoid the edges of conjunctiva so that there is no bleb leak. Go as posterior as possible, and the time and the concentration of mitomycin can be used depending on the case that you are doing. So it can be varied from 0.2 to 0.4 milligram, and again the duration can be varied depending on the indication. And again, irrigate very nicely so there is no antimitotic agent left in the cul-de-sac. Now, Dr. Pencaw has very beautifully shown that posterior flow is all that we want, because we want to avoid the overhanging the anterior blebs, which can be associated with a lot of complications. And what we can do is to, even if you're choosing a triangular flap or a rectangular flap, it is a good idea to stop 1 millimeter short of limbus so that the flow becomes more posterior. After the scleral flap, the most important part of trabeculectomy is the sclerostomy, which is the crux of trabeculectomy. So whenever you are starting to do your sclerostomy, please place an apical suture. Now, these sutures help you in two ways. They help you to, you can tighten the sutures fast and avoid any kind of hypotony. And again, you can hold and have a better view of the area where you are going to make the sclerostomy. Pre-place a side port, because side port helps you to titrate the wound. It helps you to maintain the anterior chamber and maintain the intraocular pressure as well. You have to avoid either too small or too anterior or too posterior sclerostomy, and you have to be just anterior to the trabecular meshwork. Choosing a Vannas or a Cayley sponge is individual choice, and both work very well. Now, after you have done a sclerostomy, you have to make a peripheral iridotomy, which should be adequate size so that the sclerostomy does not get blocked by the thick iris, which are very common in Indian eyes. Now, after the scleral flap and the sclerostomy and the PI has been done, we have to do a thorough wound closure, which is very important, because we know that the blebs that seal well, they heal well and they swell well. So scleral flap suture is something which is very, very important. Now you can opt. Nowadays, what we want to avoid is hypotony at any stage. So whenever you are dealing with advanced glaucomas, you can go in, or even normal glaucomas, to avoid post-operative hypotony and shallow anterior chamber. It's always a good idea to a tight flap suturing. So you can go in for a suture lysis at a later post-op period, or a releasable suture, whatever you are comfortable with. Now, conjunctival repair is again, a lot of importance, because we have to seal each and every leaking point at the table. So if you are doing a fornix place flap or a limbus place flap, you can choose your sutures accordingly. You can choose a monofilament nylon, which works very well, or a vicryl. And again, if you have done a limbus based flap, you can suture the conjunctiva in 2 layers, tenon separately and the conjunctiva separately. And if you are in doubt, it's a good idea to use fluorescent to check for any kind of wound leaks, because they should be repaired at the table. Now, once you have done the surgery, it's always a good idea to cycloplegic the patient. So what I usually do is atropinize the patient and do a tight bandage. So in case if there is a slight ooze from the suture site, it can get self-sealed. And always put the patients on steroids, and steroids are usually required for a long time, maybe up to 3 months, and depending on the vascularity and the angry appearance of the bleb, you can taper the steroids as per the need, depending on how the bleb is behaving, along with the antibiotic and cycloplegic complication. Now, once you have done a trabeculectomy, in the post-operative period, you follow up your patients, and if you're planning for a suturolysis or a suture removal and you've done a releasable suture, depending on the intraocular pressure, you have to titrate the timing of removal of these. So it's a good idea to wait for a week, because this is the time the bleb is settling in. There is a slight amount of inflammation or healing happening. So good idea to control the pressures if they're high with the anti-glaucoma medication, and do the suture removal after 5 to 7 days of trabeculectomy. So I think at the end, I would like to say that it is very important whenever you are planning your filtering surgery to identify the patients at risk, control their systemic factors nicely, achieve a good preoperative lower intraocular pressure, use a low volume anesthesia and go in for a good exposure, use a non-charring cautery and minimal cautery, and go in for a wider application of mitomycin C. Leave your scleral flaps 1 millimeter short so that you can have a posterior flow. Apply pre-place suture before you are making a sclerostomy, and titrate your wound. And at the end, achieve a watertight wound closure. And with this, you can achieve a good and a successful outcome of trabeculectomy. Thank you for your kind attention.
Thank you, Dr. Parul. I think we'll take a pause, and we will invite questions from the audience for these 2 topics. Then we'll go ahead with Dr. Manav's topic. Any question from the audience? Choosing the right surgery?
So I like to point out one thing which is very important, and which Dr. Parul also said, that during the surgery we should not permit the AC to become flat. As soon as you are making sclerostomy, put in some air, because the flatness of the chamber even for 30 seconds may lead to a choroidal detachment later on. Mostly people say choroidal detachment is a cause of hypertony. In fact, mostly it is a hypertony which is a cause of choroidal detachment, and not vice versa. So
I think Dr. Manadip is very, very correct. Dr. Parul has also stressed on the hypertony. I can tell you, I'll also like to repeat it, because hypertony is mother of all the complications post-operatively. Whether you talk about the lenticular changes, you talk about the choroidal expansion, you talk about the choroidal effusion, or suprachoroidal hemorrhage, anything you talk about, or malignant glaucoma, anything, the hypertony is the mother of all the causes. How you have to prevent it is the first thing. At no point of time during your surgery, the antechamber should be made flat or shallow. The reason being, the scientific reason is, choroid is very spongy structure, expansible, and its volume is 480 microliters, where the antechamber depth is 150 microliters. So that means a 20% expansion of the choroid when the chamber is made flat after opening the antechamber is enough to occupy the antechamber. So keeping that scientific background in mind, that the choroidal expansion should not occur during surgery at any point of time is most important. Forming the antechamber after the surgery is of no value. You have already caused the damage. So that is more in susceptible cases like high myopes or vulnerable eyes, like post-vitrectomized eyes, non-ophthalmic eyes, where the expansion occurs very suddenly. Even you open it, the atmospheric pressure comes down to 0, and there is a difference in the choroidal pressure and the atmospheric pressure, and the expansion starts, and that is the cause of coronal effusion, that is the cause of coronal hemorrhage, is coronal, everything starts after that. So it is vital that you see that the antechamber is not made flat or shallow at any point of time. The best way of doing it is to pass sutures in the scleral flaps, and see that temporarily you may have to use little viscoelastic in the antechamber after you have made a small incision, then and keep ready that as soon as the antechamber, the trabeculectomy is done with the Kelly sponge preferably, because that takes much less time. 0.75 millimeters, 2 bites is enough. 1.5 millimeter of the scleral opening is enough, and do a PI which is bigger than the sclerostomy area. If you can do it in a very short time, without causing any shallowness in the antechamber, by injecting little viscoelastic into the antechamber, you have made the success. And after you have passed the two sutures and you tighten it soon, antechamber will remain as deep. In worst cases, where you expect that the chances of coronal effusion or coronal hemorrhage is more in cases of very high myopes, vitrectomized eyes, with post-vitrectomy surgeries, or in anophthalmic eyes, in such eyes one has to be really more careful, and in that cases you may have to put a side port, keep the antechamber filled with the normal saline, and keep the antechamber formed whole lot of the surgery. At the end of the surgery, you see that the titration is complete. It is not causing free flow. It is causing a very guarded flow through this through the scleral flap you have made, and antechamber is maintained. If on the table the antechamber tends to collapse, be 100% sure that will land with a flat antechamber next day. And you expect the antechamber to be low, to be shallow, not on the first day. It is always the second or third day you expect the antechamber to be shallow. So first day is important, but second and third days are more important as far as the shallow or flat antechamber is concerned. So that is because in some cases it takes little time to build up, and it is 2 days, 3 days. Spieth has quoted it as such. Yeah.
Again, very important, which I think I forgot to mention, that you have to release the traction suture. So whenever you are making a sclerostomy, please remember that you gently, if you are using a superior rectus or a corneal traction, just make it little lighter so that this, the sudden hypotony does not happen. This is also a very important step while you are making a sclerostomy. I think.
One, 2 points. Can we highlight 1, 2 points? So how many people really? Dr. Ritu has some.
I wanted to ask about releasable suture. What is the best time to release the suture, and how much drop in pressure you're expecting when you're pulling out one releasable suture?
Dr. Ritu, what I usually do when I put releasable sutures, I try a little bit of, if the pressures are high on day 1, you try a little bit of digital massage and see if the bleb is forming. So that means, the flow is happening and the sutures are preventing it. So you can still wait for 1 or 2 days. You don't need to immediately release the sutures. So I usually start from 4th day. I don't release it on day 1 or day 2. And gradually, if you put 2 releasable, you release 1 at a time. So do a sequential suture removal. And, digital massage gives you a very good idea that, is the bleb going to function? Because what you are scared is the sclerostomy opening is sufficient or not, and the ostium is open or not. So that is what my take about suture removal is.
May I say a word on this, sir?
Yeah, please.
My figure is 10. The moment pressure crosses 10, that's the time to release the sutures. But there are 3 conditions to this. One is, never do it in the first 4 days. Secondly, never release 2 sutures at a time. And third is, must observe the patient for 1 to 2 hours in your own clinic after you release the sutures. So this is how I do it.
But how
So
much
according to the books, actually 2 to 3 weeks time when you tend to remove the releasable sutures. But to me it appears 2 to 3 days too late. Even if you release the suture after 2 weeks, nothing is going to happen, because the scleral flap is sufficiently firm to keep adhered to it. So it is useless to keep this releasable suture for 2 or 3 weeks, then start using it thinking that after little massage the chamber will, the antechamber, the IOP will be controlled. But this doesn't happen. So it is that first 1 week and maximum of 10 days to 12 days. That's the time when I have to regulate the releasable sutures. Whether this is releasable suture or adjustable suture, you have to see it in the first 1 week to 10 days time. It is only helpful, otherwise releasable suture has no role actually. If you have passed the sutures carefully, titrated on the table, releasable suture is not necessary. It is only on very specific situations, like where you do not want the hypotony postoperatively with the thinking that there will be choroidal expansion and hemorrhage, and there will be blackout phenomenon. In those situations, the postoperative spike can be, immediate postoperative spike can be prevented by releasing the releasable sutures even before 1 week's time. As Dr. Manav said, you can intervene little early and loosen it one at a time if the pressure spike is high in those vulnerable cases, advanced glaucoma cases. Otherwise, if you go by the book that you remove after 2 to 3 weeks, I think you are not doing anything for that.
And another thing which Dr. Manavdi pointed out, that you have to observe the patient, because sometimes what happens, you pull a suture and hyphema happens, and so you're managing one complication and you land up in another complication. So you have to do it very diligently and observe the patient very nicely after that.
How much drop are you expecting? You said 10 is your cutoff. So
Yes, 10 is my cutoff.
So if you pull one suture, what is the pressure you're expecting after releasing it?
Anything between 6 and 10. And it may remain at 10 also. You don't need to do, massage. If you massage only, then it will go further down.
Yeah.
Sagarika, you can come here.
Sagarika, here is the mic. Please take it. Here.
Use this mic. Any mic.
And do a strong massage. Don't do that. Do a very gentle massage. See the bleb is forming. Wait. Then wait, and Dr. Madhavdev said, please hang on and wait. Don't allow the patient to go. I have seen where we have removed one suture and suddenly the AC has become absolutely flat. Don't do anything. Don't get disturbed. Allow the patient to sit. It will form again. The important thing is watch. Be aware. You can have hyphema. Be aware of what is happening. If you just take out the suture and tell the patient to go, you'll land yourself into thick shit.
There are one, two very specific practical situations I will certainly like to highlight, and I'll share my experience of maybe so many years. One, the preoperative mannitol. We have got the tendency to give a preoperative mannitol if the pressure is slightly on the higher side, maybe 22, 23 and 24. Then we give a preoperative mannitol. I personally feel, after so many years of experience, mannitol sometimes causes more harm. Even if the pressure is 30, 35 and it is not brought down with the medications, I think on the table giving mannitol becomes little more problematic, because mannitol has 6 hours effectiveness. After 6 hours, there will be a rebound phenomenon, and the vitreous becomes more, absorbs more fluid, and the antechamber tends to flatten up. So if you have done a very slow release on the table, very slow release, take maybe 15 seconds to release some of the aqueous very slowly and comfortably, then you can do the surgery very comfortably, and there is no need for any mannitol. And mannitol, in fact, as Dr. Parul said, that the patient may be always disturb you on the table, plus post-operatively after 6 hours it will a rebound phenomenon and the chamber is likely to tend. That is one thing. Second modification.
Sorry, sir, I just want, because I don't know, I would like to take an opinion from other surgeons. What is your take on mannitol? Because I routinely give mannitol to all my patients, so I think I'm not saying that. Yeah, I know that's what I don't know.
No, I just said
Yes,
this
we really
is the
respect
personal.
that.
Surgery is always very personal thing, and you must give respect to your own surgical results and surgical hand.
Absolutely,
What
sir.
what I expressed is my opinion for last so many years. That's all.
Start off with
Yes,
Dr.
I think
Manavi.
we will have
But
this discussion,
mannitol,
yes.
I think, is something that I definitely depend on.
Yes. So I think we will have the discussion
don't,
later
don't
on.
forget that Diamox can cause a
Yes,
dead
yes,
patient
yes.
tomorrow
Agreed.
morning.
Agreed, sir.
Diamox, one of my patients has died. I started preoperatively on Diamox a week before because the patient was on multiple drugs. He was living alone, 75 years old. I did a wonderful trabeculectomy. By evening, the patient landed up in CCU, and we realized that the calcium, potassium was 1.5, and the patient was not taking supplements despite having been prescribed because he was alone, 75 years, little depressed, and the patient died in the night, even after doing the best care. So all these things you need to take care, and with that, I come to the mother of all complications in the words of Dr. Das, and thank you very much, Parul, and thank you very much, AIOS, for the opportunity. So, I have no financial interest. It's a standard disclaimer. As we heard in the previous talks that there's always a confusion whether to have medical treatment, early surgery without MMC or with other things. That confusion gets solved and you do surgery. And AC is flat on day one, and the patient and the surgeon is like this, crying and consulting others despite the fact that he is a well-known surgeon. So what are we scared of? The two things, the leak and malignant glaucoma. Rest of the things are innocuous. So these are the ideal things that we want to see on the first 2-3 post-operative days. Slightly shallow AC with IOP of 6 to 10. Early and late post-operative appearance, that is what we desire. So the AC can be flat or shallow with elevated IOP or with low IOP. With elevated IOP is uncommon, but it does happen, and can be ciliary block glaucoma or suprachoroidal hemorrhage. Retained visco is a rare possibility. And with low intraocular pressure, it can be overfiltration, which is innocuous, wound leak, little more dangerous, choroidal detachment, which is generally the effect and not the cause of hypotony. There are other reasons too. Incidence of overfiltration as well as leak has increased due to use of antifibrotic agents. However, lately in the last few years, releasable sutures have become very common and they have reduced this incidence. Grade 1 and 2 are the peripheral touch. These are innocuous and can be managed medically, whereas grade 3 of the shallow chamber is the irido-lenticular touch. It is a surgical emergency. The principles of surgical treatment for grade 3 is that it can lead, this is actually required because this is a surgical emergency because it can lead to cataract formation, anterior and posterior synechiae, as well as endothelial cell decompensation of the cornea, not within days but within hours. The immediate treatment is AC reformation with air in case of leak and viscoelastic in the cases of overfiltration. It is done immediately in the clinic on slit lamp. However, resuturing can be planned better in the OT at an appropriate time. So, the Bleb leak, the intraocular pressure is generally 0 or maybe up to 6. Anterior chamber is shallow, the Bleb is shallow or flat, and the diagnosis is confirmed by CDOS test, which you can see here. And the site is generally a conjunctival suture or an area of conjunctival buttonhole. The treatment can be conservative. You stop the topical steroids and start oral so that inflammation is not there. Gentamicin, tobramycin, these are fibrotic drugs. They cause fibrosis, so they help in reducing the leaks. Atropine is mandatory in these cases. Pad and bandage can be given. Large bandage contact lens can be tried, but generally they don't work. Autologous blood injection again is not my favorable, although described. The treatment can be either laser or surgical as well. Argon laser photocoagulation using large spot size after staining the area of leak with gentian violet or trypan blue can be done. 500 is the minimum size that we need to use, or we can use even 1000 micron. The suture removal can sometimes be required because between the two layers, between two raw surfaces, you need to have a direct contact. Sometimes a suture pops up in between and it does not let it heal, and removal of suture may help you to heal the leak. Of course, resuturing is the final answer. The distal edge of conjunctival leakage sometimes can be at the limbus, and in case you are suturing at that time, please remove the epithelium from the cornea because suturing will have to be done conjunctival corneal. It may require lens removal if cataract has already formed if the shallowness persists, and this is what it is, cataract developing within hours. Excessive healing of topical steroids, the problems related to bleb leak are multiple, and all of them ultimately lead to bleb failure, as Dr. Das had described in his introduction. Hypotonic maculopathy is less common in leak. It is more common in overfiltration because a sufficiently long period for it to persist is required. A low intraocular pressure will always have a tendency to pull the things from the surface, leading to endophthalmitis. The hypotony due to overfiltration is unlike bleb leak. It's generally the bleb is generally raised and not flat, and it is relatively innocuous, as I said, settles on its own, can cause significant hypotonic maculopathy. Hypotonic maculopathy is more common, as I said, in overfiltration rather than in the leak. So this is what you can see, elevated bleb with shallow AC in overfiltration. The treatment is mostly conservative with oral steroids and atropine, and one may need to inject intracameral viscoelastics for this, and argon laser photocoagulation from the sides can be done if the bleb is very large. The final answer is the surgical, that means the tightening of the scleral flap, but it generally will lead to failure. The Pomberg suture usually must have a scleral bite, which is practically very difficult to give because otherwise the suture will not work unless you have taken sclera into the bite. Ciliary-choroidal detachment may be cause or more likely effect of hypotony, as I said, may be subtle and hardly visible even on UBM. However, it can be as large as kissing choroidals. Reduced visual acuity may be a very, very early sign. If a patient post-trabeculectomy comes with a reduced trabeculectomy, generally you have a small ciliary detachment which you will not be able to detect unless you do a UBM. Generally settles on your own, on its own with steroids, topical and oral, as well as with atropine. If it does not settle in 2 weeks' time, that means you need drainage. The flat AC with elevated intraocular pressure can be pupillary block or magnet block, or it can be suprachoroidal hemorrhage. The diagnosis can be confirmed by ultrasound. The expected elevated of IOP in the first 2 to 3 days is the expected pressure is 6 to 10 millimeters of mercury in an ideal trabeculectomy. So in case the pressure is 14, 15, 16, it may be a normal range, but it can still be malignant glaucoma. So there are 2 mechanisms which can be differentiated by UBM. First is it can be caused by ciliary body detachment and anterior rotation of the ciliary body. AC here is flat and lens iris diaphragm is rotated forwards, causing mechanical angle closure. The treatment in these cases is medical and surgery only if it fails, and the surgery is suprachoroidal drainage. The second, which is the most dreaded complication, which we all actually talk about malignant glaucoma, is the aqueous misdirection without ciliary body detachment. Here the AC is flat and lens iris diaphragm is rotated forwards, causing mechanical angle closure, and the treatment is surgical, that is the rupture of anterior hyaloid face or drainage of the aqueous which is collected on the back side in the vitreous. So it is more likely in chronic angle closure glaucoma where there is no PI done preoperatively, and it can present soon after surgery or when cycloplegics are stopped. If one patient has suffered from this, the other eye is also likely to have the same problem. This is very, very important. And prevent in the other eye by using preoperative reduction of intraocular pressure as well as blood pressure and post-operative use of very strong cycloplegia. Here you can see the aqueous pockets in the vitreous which may sometimes be visible and may require drainage if required. This is a case of ciliary block glaucoma following cataract surgery, which I wanted to highlight that it can happen not only after trabeculectomy but after other intraocular surgeries as well. So the treatment is medically in 50% of the cases, and something I want to highlight is a cycloplegia which is required in these cases very strong. Atropine, what we have available in the market is 1%. However, we may need to make from the injectable as 2, 3, 4% and add to this phenylephrine so that we can have the maximum cycloplegic effect. The lasers can be used in this to open up to do the anti-hyalodectomy in case the patient is pseudophakic, and the full surgery means the aspiration of the fluid using 18-gauge needle on 2 ml syringe passed through pars plana after making sclerostomy. For this, you have to see the fluid cysts on ultrasound B scan. Otherwise, you may not be able to do this. Or otherwise, if everything fails, then vitrectomy is the answer, and occasionally you may even need to do lensectomy. Thus, to summarize, post-operative flat AC is a serious complication of incisional surgery for glaucoma. Mostly one of the 4 reasons of the flat AC are there, and 3 are with low and 1 is with a high IOP. IOP decides whether it is malignant glaucoma or otherwise. Most cases can be managed conservatively. Iridolenticular contact is a surgical emergency. Although YAG laser capsulotomy with anterior vitreous face break may help in pseudophakics, vitrectomy may be required in malignant glaucoma. Eyes with malignant glaucoma may require lifelong atropine. This is very important. They may require lifelong atropine. The fellow eye is at high risk of malignant glaucoma, and prevention is the key to success. Thank you so much for the patient listening.
Thank you, Dr. Manavdeep. I think we are running a little short of time, so we will go on to the next talk. This is about managing the leak and overhanging blebs. Dr. Mayuri Khamar. I think Dr. Mayuri Khamar needs no introduction. She is been practicing in field of glaucoma for almost 35 years and has been actively involved in teaching and has worked as a faculty at RIO. So, Dr. Mayuri, please. Yeah.
Thank you, Parul, for giving me the opportunity to be co-instructor. My previous speaker has talked a lot on the leak, and so I will share few of my cases, how I manage those cases to stop that leak and the overending. So when to intervene if there is a leak. If the patient is having visually significant symptoms, you need to do the things immediately. And the other consideration are the possibility of the endophthalmitis or imminent risk of bleb failure if patient has a persistent leak that will lead to flattening of the bleb later on due to fibrosis. And choroidal effusion could be one of the sequelae to the hypotony. And the other specific reason to hypotony depends on the cause and the extent of the problem that you have. An extreme low pressure, for example, may call for the different response than the moderately low pressure. So this is a case, 39-year male who had both eye primary open angle glaucoma since 4 years, had a left eye trabeculectomy with mitomycin C by us. Day 1 was very nice, 7 millimeter of mercury was the pressure, 6/9 vision with his own glasses, well-formed chamber, well-formed bleb, you can see the air bubble, and wound was okay. On 5th day, he reported to our clinic with the discomfort in the same eye. The vision was 6/9 and the intraocular pressure was 8 millimeter of mercury, but on slit lamp examination, we could see some cells and flare in the chamber, which was again of a normal depth. And the bleb was diffuse, non-elevated bleb, but the wound appears to be well sealed. So what to do next? We did the Siddle test in this patient. And what you see here, a small hole just on the area of the trabeculectomy wound. And the Siddle was positive in that particular area. This hole was 3 millimeter away from the limbus, away from our wound closure. So what do we do? We did the B scan. It was normal posterior chamber, no choroidals were detected. Now these are the options that we have. Either you pat the eye, of course you control the inflammation and observe the patient, or put a bandage contact lens or a scleral shear if the hole is quite away from the limbus, or you can straight away go with the wound repair. What we did, we applied the 14.5 millimeter diameter bandage contact lens, which covered nicely the hole which was here, and gave him topical steroid, increased the dose of that same, and cyclopentolate drops, asked him to come next day. There was no flare and cells. On day 3, the size of the hole decreases. We kept the BCL on for 5 days. After removing the BCL after 5 days, we could not see the hole and the CIDL was negative. So what the message take home here is, even the conservative management can take care of the small leak that you have. So atropine, yes, it does play a role in this patient when you have an inflammation also. Now another case, let us take now overfiltration. Young male myope who also had a trabeculectomy with mitomycin, 200 microgram, 2 minutes before 1 month. And he came with a large cystic bleb. CIDLs was negative and the intraocular pressure was 2 millimeter of mercury. See, the point here is young myope. These both conditions you should be very careful when you use mitomycin C, because these are the patients who are likely to develop hypotony. So this was the overfiltering bleb. Choroidal detachment was obviously seen on the slit lamp, and B scan also showed a huge choroidals. So he needs something to be done. So what we did, we take the compression suture in this patient. Conservative management failed. We gave him something for 2-3 days, but it was not working. So we took nylon suture and horizontal compression sutures were taken. The suture started at limbus, and the posterior suture was, as Manavdeep said, you have to go through the sclera at the edge of the bleb. It is very difficult because of the hypotony. It is very difficult to pass the suture through the partial thickness of the sclera. And this was the picture post-op day 1. You can see the compression suture here, which has compressed the bleb nicely. And this is at the end of 3 months. Flat bleb, pressure 12, good form anterior chamber depth. So simple suture can also save the bleb. This is another case, a small video clip how to pass the suture in the overfiltering bleb. As I said, the white bite was taken from the partial thickness in the cornea. And then you cross the suture. And that posterior bite should be taken at the posterior to the posterior edge of the bleb. And then tighten it sufficiently so there is a compression of the bleb. And then once you finish, rotate the knot, bury it, and observe this patient. Now the overfiltering blebs should always be managed nicely, and it is more commonly seen with the full thickness surgery. Nowadays we don't do that, but it was more common with those type of surgeries. And usually it gives the foreign body sensation, astigmatism, unacceptable cosmesis, and these are the dysesthesia. These are the problems which needs to be attended in this patient. And the large bleb gradually extends downwards over the peripheral cornea. It becomes overhanging bleb. And Dallon formation also leads to the overfiltering bleb. So conservative management could be simply lubrication initially. You can apply the laser burns. Argon laser can be used to do that, or cryo application, or TCA cauterization may be done. But usually this all fails when it is a huge bleb. In that case, you need a surgical revision, particularly advanced cases where hypotony is detrimental to that field, or there is a Dallon formation. So 3 strategies can be taken: partial excision of the overhanging corneal portion. Then you can excise the bleb and free conjunctival autologous graft, patch graft can be done, or you can do the conjunctival advancement. Always remember, if you remove the bleb, you have to counsel to the patient that you are likely to have rise in intraocular pressure and you may need anti-glaucoma treatment later on. This is a very simple step to show you. See, the overhanging bleb has nothing firmly attached to the cornea. Just lift it and cut it. It is a non-functioning part of the bleb. So it is very, very simple to do that. Then, you want me to? Late onset thin cystic overhanging bleb like this. This is a case. How we manage that? This patient had a leaky cystic bleb. You can see a small hole. It heals later on, and again it is opening up, and so fluctuating vision was the problem with this patient. So what we did the conjunctival advancement, try to preserve the bleb because it was not a bad conjunctiva. If it is a necrous conjunctiva, I would have removed that. This is another case, a small clip. First, open the conjunctiva from the peripheral part of the bleb. A small frill is also kept, and now with the two-side incision, you can release the conjunctiva, pull it down, and first fixation suture is difficult. Now always make this corneal debridement. Remove the overhanging bleb. The cornea should be raw, otherwise this conjunctiva will slip. It will not stay there. So first suture is taken like this, and then you can have a running suture.
Dr. Mayuri,
Alternatively, with the...
we're running little short, two more talks.
What happened?
We're running little short of time, please.
Okay, I will finish this. And this is a small scleral melt underneath that. So what we did, we removed the conjunctiva from the above necrous part, put the scleral patch graft, and then cover the conjunctiva. And this also worked good with us. So conservative management or whatever is required should be done. Thank you very much.
Thank you, Dr. Mayuri. Meanwhile, Dr. Sagarika is coming. We can take a question. Dr. Mayuri also very clearly pointed out that, in high myopes and along with glaucoma, sometimes using anti-mitotic agent could be a challenge, and you can land up in hypotony and overfiltering blebs. So, Dr. Das, what is your take about, what is the adjunct that you would like to use in a myope who has glaucoma and advanced glaucoma so that you can avoid overfiltration and thin blebs post-operatively?
Before I reply to your question, but one, two things I will certainly say that the prevention is the best treatment as we always follow. For the, bleb leak or for the overhanging bleb and for hyperfiltration bleb, we are responsible for it. This surgeon in a hurry has not sutured the conjunctiva properly and has run away. And he didn't have the time. He has done a big sclerostomy and didn't apply the sutures properly and not titrated. He has landed with it. So for these serious complications, or even he has done the sclerostomy much posterior beyond the scleral spur and landed with suprachoroidal drainage and with hypotony. So these things can jolly well be prevented by the surgeon if he is careful enough. That is one thing. Second, sometimes you come across with the ciliary body suck with the application of the mitomycin C. So that has to be kept in mind. And some patients are abnormally sensitive to mitomycin C, and there may be ciliary body shock. You have to keep a watch on it. Systemic steroid will help postoperatively in these cases. All right. I think we want.
Forces for many years, and she was one of the first lady doctor to be posted at the highest medical facility of India, Leh, and she has enormous experience, and she'll be talking about managing the failing blebs. Dr. Sagarika.
Thank you, Dr. Parul. Practically a large numbers of aspects have been covered up and talked about. So what is it that we mean by an ideal functioning bleb? When we see a bleb which is low-lying, it has got very less vascularity, cystic changes are present, the intraocular pressures in the low teens, let's say, it's a well-formed anterior chamber, it's got a tight conjunctival suture, all that indicates that it is a very good functioning bleb. Anything which deviates from this, we know that's probably not functioning. But suppose we have a non-functioning or a failing bleb, we have to recognize what is the cause of failure, identify that cause, and then deal with the intraocular pressure, and we have to try and restore the function. So you can, best is actually if you can do a good gonioscopy. I know this has never been stressed upon, but I feel a very good gonioscopy post-operatively, you can identify the sclerostomy, whether it is blocked or not blocked. Now, suppose it's a bleb leak. I'm not going to talk about it. It's been already dealt with many times. Already many of the doctors have dealt with it. Now, suppose you have in the early postoperative period, you've got a flat bleb. Pressure is very high. You've got a deep anterior chamber. Do a gonioscopy, rule out blockage at the sclerostomy site. If, let's say, the sclerostomy is maybe blocked, it may not be blocked. There may be blood clot over there. There may be fibrin over there. Just do gentle massage. You have to teach the patient or relatives how to do the massage. Increase the steroids. If you've got a vitreous blockage, do an Nd:YAG laser to break the blockage. You must try to do repeated massages. Let's say, okay, you've done the massages, that's been unsuccessful. Try to remove the releasable suture or do an argon laser suturolysis of the fixed scleral flap sutures which are present. This has already been discussed by many of the doctors out here. Approximately 10 days post-operatively, it is more or less safe. If it is still high, the pressure, then go ahead and do needling. I'm going to talk a little about how to do digital pressure. A lot of us do it from the lower lid. That's also fine. You can also do it by the upper lid. And this upper lid, you can use your finger. You can use a blunt-tipped instrument also. You can also use an impression by means like, for example, your Johnson's bud has been described by Carlo Travoso. You just press over there and you can comfortably do it. What is very important is you must remember that you can develop corneal abrasions if you're not carefully doing it. You can have hypotony, flat anterior chamber. You can have hyphema as stressed upon by Parul. You can have iris incarceration because of the ungentleness with which you did it. You can have coronal effusion and hemorrhage. So ocular massage is suitable for those patients who are physically capable. Now, let's say, for example, you're telling a patient who's got Parkinson's, do a massage. You can't expect him to do it at all. So who is physically capable of doing it, and when you have done an ocular massage, that patient has got a beneficial effect, then that person will probably benefit from it. You can also release these releasable sutures. We must know how to release the sutures and when to release. A little bit has been talked about it, but remember that suturolysis and all this depends upon the amount of mitomycin you have put, how long you've put the mitomycin, how tight you have put the sutures, and also remember it is the patient's tendency to fibrosis. A lot of patients fibrose very fast. It's very difficult. I'm not going to go into the methods, but what I would like to tell you is you can use both the diode laser as well as the argon laser. And if you do, let's say, suturolysis before the third postoperative week, there is a slight risk of hypotony. We must not forget that. There are certain limitations also of suturolysis, like suppose you've got a thick overlying Tenon's capsule, you've got postoperative inflammation, subconjunctival hemorrhage, then they're not really likely to survive. Now, you can also remove the releasable sutures, which can very comfortably be done on the slit lamp itself. But please be careful. Take a sterile needle. In these days of lawsuits, please show the patient that, look, you are taking out a sterile needle, you're bending it in front of them, or you're not bending it, you don't need to do that also. But please show the patient, please put antibiotic drop before and after, and only put 1 drop of paracaine, and you can comfortably do it. Don't put 2 or 3 drops of paracaine, you're going to ruin the cornea. You can also use adjustable sutures. I don't have experience in it, but yes, Pencor definitely does it. And as per him, he uses his own suture tying forceps, and it is very easy. So you can also use anti-proliferative therapy. Now, in RP Center, I think Parul and everyone will bear with me, we used to take mitomycin and 0.2 milligram per ml, and on the postoperative, take the patient into the OPD, and then on the bleb, put this in the form of sponges, and then after that, keep it for about, say, 2 minutes or so, remove and wash it thoroughly. Do it for 3 consecutive days. This also would help in revival of the bleb. Next is that if you've got an encysted bleb, try to give aqueous suppressants. And you can also do bleb needling. There has been a prospective study in which they have found that it's better to do medical therapy using aqueous suppressants over needling of the bleb in management of encysted blebs. This is of one child who was a 4-year-old who landed up with this. Now, let's say all this fails. You've tried everything. Everything has failed. Then you go as to what has described by Pencor as bleb needling. And again, do a sclerostomy to see whether your sclerostomy site is opened or not. You can give mitomycin or any of the anti-proliferative agents away from the wound earlier, and after that, go ahead and do it. And let's see, you can do this in the OPD itself, on the slit lamp, and it's very easy to do it. But important thing is take pure aseptic measures, and then after that, see, you can just comfortably, this I'm doing it on the slit lamp, and you can break the adhesions over there and this can result in a beautiful bleb. Now this is when we are using a trocar. This is in the OT, and we're using a trocar over here, and we can in fact remove this thing of sorry, it's not moving. I'll go ahead. And don't forget that even bleb needling can result in a lot of complications of hypotony, early complications, late complications. Most important complication is blebitis and endophthalmitis. Don't forget about that. And even this simple procedure can land you up with malignant glaucoma, which Dr. Manavdeep has talked about. Now, this is another thing which has come up, and this is by Davinder Grover and Feldman. And we have used this procedure in which first, when you're finding that your bleb has failed, it may be even 10 years after surgery, and so you give mitomycin injection away from the wound and approximately just 0.5 ml into the subconjunctival space, and a week or so later, then you do this bleb needling. But this is an ab interno bleb needling where you anesthetize the eye, and then I'll just show you a small video on this. And see, after that, so you first put your gonioprism, you have a look, where's your sclerostomy site? You can see the sclerostomy site over there. Try to mark it. I didn't have a proper good gonioprism, so therefore I used this one only. After that, fill your anterior chamber with lots of viscoelastic, preferably a thick like Helon or let's say Helon GV, and then use the Feldman spatula and then go into the bleb. This is the ab interno procedure, and try to break those adhesions. See, you can see I have gone into the bleb and I'm breaking all those adhesions. You can come back, have a look at it again, and again proceed forwards, and then goes right through the sclerostomy, and you can see it so beautifully, it then breaks off. Now, we really couldn't make out, are we really being able to do revision? Is something really happening? So my operating room assistant told me, ma'am, why don't we put a little bit of dye? So I put dye, and there, lo and behold, we find that, the bleb, the dye has come out, thereby showing us that definitely this is working. So this is a very, very good method, and I will tell you about just one case, and that is, this is a gentleman who was 76 years old. I operated did a phaco trap for him in the Armed Forces Medical College in 2011, and he was a single-eyed patient. This was his only eye, and his PL, the left eye was PL negative, and then he kept on getting treatment done in Leh itself on the follow-up with Travacom till March of 22. So 2011, 2022, 10 years later, his pressures rose up. That is up to 34. We gave him all the treatment that was possible. Ultimately, he came down to Delhi, in which I did a subconjunctival mitomycin, the same procedure which I've told you. And then after that, I did the bleb needling. The video that you've seen is of this gentleman. And after that, we found that, see, therefore, he was a PEX glaucoma, and you find that this was how the bleb was before, and he had advanced glaucoma in one eye. I want to show you how the IOP changes. See, on 12/3, first the IOP was 12. It went down to 2. This is ciliary body shock. He was mildly myopic. This has been stressed upon. A person who is mildly myopic, please don't forget that you can land up with ciliary body shock. Now, this patient was just on timolol. It has risen up to 14, and the patient is now on 2 drugs. Even if we can save this eye, this one-eyed patient with just 2 drops, we have done a great job. Thank you so much.
And thank you, Dr. Sagrika. I think we have just time to take one question. I would like to ask the panel and Professor Das and Professor Manavdeep Singh that in cases, of failed trabeculectomy, what is your threshold? Till what time do we think that we can consider a needling, or when do you decide for a repeat trab?
Can I answer this question since you have asked me? You see, if a patient, it depends totally on the patient's optic nerve. If the patient is, for example, one-eyed, and the patient has got a very large glaucomatous optic neuropathy, my threshold is very low. By your attack, before that person goes blind, you can't afford to wait. Therefore, you can give him a little bit of good bleb revision. Mind you, these bleb revision, especially the ab externo ones, we all know they really don't work all that well. And sometimes they work very well. I've done so many of them, but sometimes they just fail because you can't see the edge of the wound. And as a result, you can't go in. Whereas if you do an ab interno one, I've shown you, it's there. It goes along, and So that if suppose we find that no, the patient is not going to be able to wait for that long, then go ahead and do a retrab. But mind you, a retrab in these cases also, it is fraught with complications. So you have to be very careful. Thank you.
I think I think with the needling, so do it within 1 month. If it is bleb revision, wait for 2 or 3 months. But as Dr. Sagarika correctly said, that if the condition is very precarious, it is an advanced stage of glaucoma, it's very severe, I think early intervention may be necessary.
Dr. Manavdeep, you want to add something before
No,
we
I
close?
think what Dr. Das and Dr. Sagarika said completes the issue, so I don't need to say anything. Thank you.
Sorry, we couldn't share a lot of practical things with you because of shortage of time.
Thank you so much for attending this session, and thank you AIOS, and with this we close this session, and thank you Professor Das, and thank you all the co-instructors.